Mitigation COVID-19. This is our 7th CBD program, and there are about 120 doctors participating with us today. And this is a 1-hour workshop which is done by Dr. Mahen Kotalawale, consultant clinical microbiologist at National Hospital Kandy. Please be kind enough to mute your microphones and your video cameras during the workshop. And if you have any questions, you can direct them to the lecturer panel by using a chat box. Now I warmly welcome Dr. Mahen Kotalawale to start this workshop. Over to you, sir.
Thank you very much, ladies and gentlemen, for giving me this opportunity. And today what I thought was to discuss some aspects on COVID. So basically, I'll be talking about COVID risk mitigations for professionals. So basically, the whole idea is to have some idea about what we are going to do to prevent spread of COVID-19 among healthcare workers. So basically focusing on that aspect. So before my presentation, I would like to introduce the two words that I am going to use throughout my presentation. That is risk and mitigation. So what is a risk? So if you take the word risk, it says avadanama or avadanam. Then what is the term mitigation means? Awama kirim, right? So in my this 1-hour talk, basically focusing on those two words. So how do we involve in reducing risk of transmission of COVID first among healthcare workers and then to the community. So in my presentation, I'll be using this frame to present to you whatever the facts that I have to produce to you. So first, I'll be talking about two examples of nosocomial spread of COVID in Sri Lanka. Then I'll be giving you the concept of risk scale of acquiring COVID-19, moving to transmission dynamics, and then viral transmission, and the factors which govern the transmission of COVID within the community and institutions. And then I'm talking about prevention of COVID-19 in healthcare setting. And then I'll be introducing the concept of exposure risk assessment, and I'll be talking about how we are going to use the risk assessment framework, exposure risk assessment framework in assessing the risk of healthcare workers. And then I'll be discussing some true clinical scenarios with you. So first of all, I would like to give you this bold statement. COVID-19 is not easily transferable. So I'm taking two examples from the hospital that I work, National Hospital Kandy. First one is the ENT clinic incidents. So in a typical day, the ENT clinic provides services for around 125 to 150 patients. So there are around 40 healthcare personnel attached to ENT clinic of National Hospital Kandy. So here you can see from this graph the basic arrangement of the ENT clinic. You can see the patients were seen in the corridors and they were asked to come in one by one to be seen by doctors. And there's a registration desk, there's audiologist room and the speech therapist room, and on either side there are rest rooms and dinner or tea rooms. So basically this is the organization of ENT clinic within our hospital. What I'm going to discuss an outbreak which taken place within these premises. So on 25th November 2020, two healthcare workers diagnosed with COVID-19. So when there is evidence of nosocomial or hospital spread, we generally further investigate into this. So on the following day, we have identified 15 additional healthcare workers who are having COVID-19. So, and this is the scenario on 24th November. You can see the red individuals, the healthcare personnel, were the carriers or the disease spreading individuals. On 24th of November, within the practicing of ENT clinic, there had been 17 contagious or infectious individuals within the practicing, the hospital unit. As a result of that, there had been 9 nurses, 4 healthcare assistants, 2 audiologists, and 1 speech therapy and 1 doctor who's from another ward got the disease. Altogether, there had been 17 patients, 17 healthcare workers infected with COVID-19 during that 2 days time period. But the cardinal feature of this outbreak is no doctors or patients got the disease. Here you can see the doctors seeing patients. There are nurses, the healthcare workers, the healthcare assistants were roaming around the theater, potentially spreading the disease, spreading the viruses all over. But instead of that, none of the doctors or the patients got the disease. So some doctors have been working on that area for more than 4 hours for 2 days, consecutive 2 days within the time period. But all 4 doctors who have visited that place during those 2 days were disease free upon testing. So we have sent them compulsory home quarantine, but after quarantine period, we got to know that none of them were infected. So if the disease is easily transmissible, like we are thinking now, right now, all 40 personnel within the healthcare institute, the ENT clinic should have got the disease. And also, in addition, there has to be some patients who was getting the disease. But fortunately for that, only 17 healthcare individuals who were infected originally were the affected parties at that place. So then the second incidence is eye operation theater incidence. 6 healthcare workers attached to eye operation theater were diagnosed with COVID-19 on 21st December 2021. So that is after the famous Brandix and Paliagoda fish market cluster. 1 detected on the first day and 2 other nurses and 5 others were detected later. So now in this scenario, 2 infected nurses who were contagious, they were having symptoms, and in spite of having symptoms, they were assisting the surgeon and anesthetist to carry out the surgery and to continue the surgical list. Here you can see with this infographic, you can see 2 nurses, one assisting and the other runner were having COVID positive, and they were actively helping the surgeon to carry out the surgical list. But no healthcare worker, the surgeon, anesthetist, or no patient were affected from COVID because of the fact that they were basically wearing surgical masks. So in these 2 instances, many healthcare workers and patients were safe, but they were not got the disease because of the fact that COVID is not easily transmissible. Why? Simply because COVID-19 is not transmissible as easily as we think. So you can see when you go to hospitals, many healthcare workers wearing this so-called PPE, the wraparounds and the coveralls. But they don't understand the fact that it is not transmissible through skin, and it has to be the droplets should come in contact with the upper respiratory tract epithelium to get the disease. So they are not concerning on covering nose and mouth, but they are thinking all covering them up with the coverall and wraparound gowns. Simply, these people who didn't got the disease were following the very basic steps of infection prevention. As a result, they didn't get the disease. All of them were practicing minimal risk minimizing behavior. So risk minimizing behaviors is the famous wear mask, wash hands, and stay at safe distance. So if you practice these things, especially wearing mask 24/7, you can get rid out of the problem very easily. All other healthcare workers and the nurses and other healthcare assistants or the doctors, they were wearing surgical masks. As a result, they didn't get the disease. And after that, I'll be moving to the concept of risk scale. Risk scale means the chances of getting infection with COVID-19. It is given as a picturesque presentation. Yeah, in risk scale consists of 0 to 100 scale. So if you were to get out of the disease and not to have risk of developing infection for 100%, you have to stay at home. So the lower risk end is staying home. The other risk end is the getting the disease. So anything, so your activities, day-to-day interactions may have a scale from 0 to 100 depending on the risk that you are going to take when you are engaging in that interaction, that social interaction. So the best way to get out of the outbreak, to get out of the disease, stay safe from the disease, is stay home all the time. But we know in practice, it is very difficult to stay home all times because of the commitments that we are having or that we are having to prevent the spread of disease. So once you move out from home, once you increase the interactions, the chances of infection will be increasing. So this photograph shows you the low risk behaviors, medium risk behaviors, and high risk behaviors of the interactions, the social interactions that you have. If you can't stay at home, the best thing to come out of the problem is to inculcate practicing or having a behavior engaging only on low risk behaviors. In that way, you can stay safe. The concept of new normal originated to define how well a person adapts to continue his day-to-day work without risking individual, the person himself or the others to COVID-19. So basically the new normal concept is to stay safe and while continuing your work. So therefore, it is very important to identify the disease and the pathogen in order to reduce transmission. The new normal involves the changing of our lifestyle to acquire minimal risk behaviors. As I shown you earlier, it is very difficult to stay home to get out of the problem. You need to interact with the society, and if so, what you have to do is you have to acquire minimal risk behaviors to your lifestyle, so that with the minimal risk behaviors, the risk of transferring or risk of getting COVID-19 will be minimized. So here you can see the changing lifestyle in order to prevent transmission. To acquire the minimal risk behavior, we need to know how this disease is transmitted between individuals. So the thing is called transmission dynamics of SARS-CoV-2. So if we know the transmission dynamics, if we know the features of virus which promote transmission, you can avoid them. And to acquire safe behaviors or low risk behaviors by everybody will delay the transmission of SARS-CoV-2. So I'm moving to transmission dynamics of, when you are discussing about transmission dynamics, you should know the ways of transmission of disease and the source and the mode of transmission. So COVID-19 is spread from person to person. It is not a zoonotic disease. It is not any other type of disease. It is a disease which transmits from person to person. An infected, contagious person forms the source of infection. So the source of infection is the human, which can be transmitting the disease to somebody else. So if you minimize interactions between individuals, between the members of society, the risk of meeting a contagious person will be less, so that you will be minimizing the risk. And the predominant mode of transmission is droplet transmission. So if you know these things, the source, the mode of transmission, you can avoid the risk of getting the infection. You can reduce the risk of getting disease. So other mode of transmissions, the contact transmission and aerosol transmission. So we will discuss about droplet transmission. When an infected person breathes, talks, sings, coughs or sneezes, droplets containing virus will emitted to outside environment. Once these droplets passes through nasal passages of a susceptible person, it will initiate the pathologic process on the epithelium of nasal mucosa. So once the virus attached to the receptors of the nasal mucosa, there is no way of reversing it. Either you use the smoke or any other steam or any other substance on or gargle or use anything, you can't reverse that. If one exposes to high viral load means high amount of viruses, the probability of infection will be high. So therefore, exposure of high viral load means exposure of more virus carrying droplets. If one remain closer to a contagious person, the risk of acquiring COVID-19 is high. Here you can see a contagious person producing droplets. You can see the highest amount of droplets are concentrated in closer to his portal of exit. So that is the nose and mouth. So as it goes further into away from the patient, the contagious person, the concentration of droplets will drastically drop. Higher the time you spend with a contagious person, the risk will be high. The probability of infection will be proportional to type of respiratory activity. So if the contagious person is breathing at rest, the number of droplets produced, contagious droplet produced by the infectious individual will be less. If you speak, it will be more than that. If you sing, it will be further increase. If you exercise, the droplet concentration will be more. Shout, concentration will further. Cough, it will go further. It increase further, and sneezing. So the type of respiratory activity decide the amount of droplets that a contagious person produce. So in that case, if you can avoid face-to-face confrontation with a symptomatic individual, the risk of acquiring COVID will also go down. Understanding the virus transmitting. So when we talk about the virus transmission, there are two important concepts that we have to understand. One is conta emission rate. It is given as ERQ. So conta emission rate means, and the second one is airborne infection risk score, AIRS. So these two concepts, if you can understand and if you can work out a plan to minimize these, you can get out of the problem of getting COVID. So first we'll see what quantum emission rate is. Quantum emission rate means, quantum means as in quantum physics or quantum theory, it is the number, the packets, the number of packets. So the amount of packets of infected particles emitted by a contagious person. So it is number of infectious particles emitted by a contagious person per hour time period. So if the number of quanta is increased or high, the chances of infection will be increased. So this quanta emission rate is expressed in quantum emission rate per hour. So generally, it believes that a contagious asymptomatic or post-symptomatic person emits around 50 infectious droplets per minute. So here he can see an instance where high quanta emission is there. So a symptomatic patient producing droplets containing viruses comes into face-to-face with a susceptible individual and in close proximity. You can see the number of quantum of infected particles will be high in this instance. The same instance, if the contagious person wearing a mask, the number of quanta produced within the time period will drop significantly. So when you have low quanta emission, the risk of infection is less. A symptomatic patient emits more quanta of droplets containing viruses than an asymptomatic patient or a post-symptomatic individual. So the second concept is airborne risk score, airborne infection risk score. So this risk score reflects the probability of acquiring COVID-19 after an exposure. So here I have demonstrated this. One contagious person sitting in front of a person who is susceptible. So this infectious person produces number of contagious particles amount X, and the susceptible person inhales a contagious particle number Y. So if the contagious person produces more infected particles, the chances of the second person getting the disease will be high. And again, if the second person, the susceptible person, inhales more quantum of droplets, the chances of infection will be high. The third parameter which comes into this equation is the degree of dispersion or destruction of viral particles from within the environment. So if the dispersion is more, and if there is more destruction of the viral particles, when it emits into the environment, the risk of infection will go down. So generally, when you multiply these X and Y, you get the risk of transmission of the disease. The reciprocal of dispersion will be the other factor which decide airborne infection risk. So when the dispersion is more, the risk is less. When the destruction is more, the risk of getting COVID is less. When one produces more quanta, the risk is increased, and when produces less when less is inhaled, by effectively wearing mask, you can reduce X and Y, and by distancing between the contagious person and the susceptible person, you can increase the dispersion and destruction of the viral particles. So in this way, you can minimize the risk. If you know quanta emission and the airborne infection risk score, we can actively take steps to reduce transmission. So when you are calculating airborne infection risk score, there are 5 parameters that you have to consider. One is room dimension. So generally, within a room, if you have a surface area of 50 square feet per person, so that signifies less sort of overcrowding. So generally, if you are working in a closed environment, you have to have at least 50 square feet of area to stay safe. If that square area is less, the chances of infection will be high. Then the second parameter which we consider when we are calculating airborne infection risk score is the infectious viral removal rate. So if you allow the air to come in, the rate will be high. If you erect any barriers, the infectious viral removal rate will be reduced. Then the initial quanta concentration, so that is the difference of quanta produced and the quanta inhaled. And then total time of occupancy. When the total time increases, the risk of getting infection will be high, and the exposure scenario. So these 5 parameters are very important when we are calculating the airborne risk score. The airborne infection risk score predict the probability of transmission of virus from source to a susceptible host. Where high airborne infection risk score will increase the transmission of the disease, and low risk score reduces the disease. So as professionals, what we try to do is we have to make measures, we have to take measures to reduce airborne contact production and also reduce the airborne infection risk score. So if we know how to do that, we can stay safe, and also we can tell others how we can stay safe during this COVID outbreak. The tools such as airborne infection risk score and contamination rate per hour will guide us to understand how to stay safe during the outbreak. Contamination rates in different settings. Here you can see a closed space, a person producing different types of droplets, the conta, number of conta. When the person is breathing, you can see from 3 planes, 3 graphs or 3 photographs, the number of conta produced with time. Here, if he's breathing, the number is less. If he's speech, the number is, and if they are singing or shouting, the number of droplets produced within a time will be increased. So if you are within an enclosure, it is always better to stay without speaking or without shouting or without singing. All these things can be done outside. The contact transmission. Contact transmission is not considered a significant mode of transmission of COVID than droplet transmission. The airborne transmission is another way of transmitting COVID, but it is basically limited to closed environments. The airborne transmission is important in closed buildings when more infected person present at any given moment. And if they stay longer within the building, the transmission risk will be high. So the risk posed by airborne transmission are reduced in outside. Still, from the knowledge that we have about the transmission dynamics of the outbreak, we can say droplet transmission is the major mode of transmission. A recently concluded study reveals that the contribution from droplet transmission is 90%. The fomite transmission and airborne transmission is 10% to all these things. So if we have means of prevention of droplet transmission, we can reduce the spread of outbreak. So the other concept that I'm going to talk is infective dose. The infective dose is the number of virions required to initiate the infection process. For COVID-19, it is believed we need around 1,000 virions to establish or initiate the disease. If you inhale subnormal levels of virus, so that is virus less than 1,000, the disease won't progress. So there has to be a threshold level of 1,000 viral particles. Infective dose always need to be expressed in relation to number of complete virus particles. It is not related to RNA levels in the sample. It's always the number of live viral particles. It is not based on RNA concentration. There are 1,000 particles could be delivered. This 1,000 threshold level can be delivered from a single exposure. So you can get a single exposure. Or this 1,000 can be delivered 10 exposures which has 100 particles each. Or it can be delivered 20 exposures of 50 virions each. So that means you can get the disease from a single exposure or gradual exposures over time. If you come into face to face with a person who is sneezing or coughing with symptoms symptoms, the infective dose can be delivered in a single step. So if you come to face with a cough of a person who is contagious, 100% you are sure that you will be getting the disease. So this is the instance where you need to have a visor. So that will prevent this splashing droplets coming into contact with this thing. Visor and uh, mask is very important for healthcare workers to stay safe during the outbreak. Breathing and soft speech will deliver the infective dose slowly over time, and it requires exposure over long time duration. So if an asymptomatic or a post-symptomatic or mildly symptomatic individual comes in contact with you, the chances of getting the disease will be less. So if you're wearing a mask, if the contagious person is also wearing the mask, you need much prolonged exposure to get the disease. When a person moves away from a probable source, the risk of transmission reduces. So in this society, we don't know who are the contagious individuals. So therefore, it is very important to stay at a distance from an unknown source. In CDC, they have found out that 6 feet is the critical distance that you have to maintain between a potential contagious individuals if you want to stay safe. When masks were worn, the contact emission will drop significantly. Hence, the risk of transmission drops significantly. A contagious person is breathing normally will release around 50 virions per minute. So at a rate of 50 virions per minute gives us a safe margin of 15 minutes to say safe 1 meter from an asymptomatic contagious person. So if you stay more than that, without mask, the risk of infection will go up, because within that time period, the threshold level of 1000 virions can be delivered to that person. When the contagious person wears a mask or suspected host wears a mask, the risk of infection significantly drops. A properly worn N95 mask will reduce the risk of transmission of COVID-19 almost by 100%. So if you are a healthcare worker, if you are involved in aerosol generating procedure with a very close proximity to a contagious person, the only way of protection is wearing an N95 mask. And I want to stress the fact that wearing a cover gown or a overall is not as protective as covering your nose and mouth. A contagious person at its height of infection per sneeze emit around 200 million viral particles. So definitely, if a symptomatic patient sneezes into your face in close proximity, definitely you will be getting the disease. The next concept I'm going to discuss is the viral load. Here you can see from this graph, the brown color graph shows you the viral load. So remember, the viral load is a reciprocate of CT value. So you get higher CT value, that means less viral load. Lower CT value, you get high viral load. But here, what I am going to show you is this line. This change is the viral load. When a person exposed to infected individuals, it will get the virus into the system attached to the respiratory epithelium. And there you have a time period known as incubation period. Here, incubation period is the time between entry of virus till the appearance of symptoms. So within this time period, the viral load increases. So once the patient is symptomatic, so that is in the green area, once the patient is symptomatic, the number of viral particles will be high. So that is why we say the antigen test will be positive within this symptomatic time period, and that is the time where the patient become invasive. So when in and around appearance of symptoms, you get highest viral load. So that is the time where the chances of spreading the virus is highest. So that is why we promote people to stay home if you are symptomatic. The highest viral loads were noted in and around the onset of symptoms. The virus load gradually wanes off with passing time. An infected person said to be infectious. So this is very important when you are assessing the risk. An infectious person said to be infectious 2 days prior to onset of symptoms till 5 days after onset of symptoms. So generally the time period goes around 7 days, 2 days prior and 5 days after this thing. So if you can avoid this time period, it's a very difficult task, but gradually, if you can avoid this time period of 7 to 8 days, the chances of getting the infection will be less. So any exposures, you have to make sure that the exposee remain isolated in this time period and you won't be getting the disease. Here you can see the disease is more spreading in first few days, that is symptoms, appearing of symptoms, and this is the time period up to first 7 days. So this is the very critical area in when we are trying to control the disease, especially in and around the time period of appearing symptoms. Any condition leading to fast respiratory rate increase the risk of emission. Cough, sneezing, and shouting will emit highest viral loads. Inhalation of higher viral loads are associated with severe illness. So this is very important concept. So if both parties, the contagious individual and the susceptible individual, wears mask, the chances of getting a severe sequelae will be less. So in Italy, they got 10 death out of the death, 10% of the deaths were healthcare workers. Basically, the reason for that is to the healthcare workers, they didn't use PPE. The Ministry of Health advised them not to use mask when they are coming into contact with the patients. So the healthcare workers were exposed to the droplets and they got severe manifestations, and many as 10% of healthcare workers out of the total deaths were healthcare workers. So that is the reason for having this thing. Low viral loads are associated with lessen the COVID-19 severity. So the low viral loads. So if you are get exposed to low viral loads, so definitely we know that the chances of infection, the severity of infection will be less with low viral load. The other concept that I'm going to talk is the attack rate. So you have to be very cautious when we are talking about the attack rate. Attack rate in the sense the number of secondary cases you get after an exposure, after a positive patient's exposure. It's known as secondary attack rate. So you get an initial positive patient, how many individuals get affected by COVID following an exposure to a positive individual. So in USA, when the USA outbreak, when they are concerning about the USA outbreak, they have found that Indo exposure will have 15% secondary attack rate, a 15% of secondary attack rate. In contrast to Indo, the outdoor exposures will give you something like 0.5%. So that means if the exposure takes place in outdoors, the chances of infection will be less by factor 30. 30%, 30 times less secondary attack rates in outdoors. If you remember the Ariale incidents or Royal Thomaian incidents, we know positive positive person has exposed to many hundreds of these things, but they didn't produce any secondary attack cases. The reason is the dilution of droplets produced because of the fact that the exposure had taken place in outdoor. Most infected with COVID-19 are either family members, so they have given family clusters, or workplace clusters. So the COVID is very, very characteristic because number of individuals infected were either from within families or within institutions. So that makes it very, very easy for us to control the outbreak if you follow the common or the successful steps. Wearing mask and distancing will have protecting influence by reducing the inhaling, the reduced viral loads. But when the time of contact increases, even mask and distancing would not be sufficient to prevent spread of COVID. Factors increasing the transmission of rate of COVID. Time spent with a positive case. We can all understand if there's more time, there will be more contact production. So therefore, the chances of infection will be high. So if you spend higher amount of time with a positive case, so that is why you get household contacts or institutional contacts. A person coming with disease stays time in the institution, you get more time with them and the chances of infection will be high. So you can see from this demonstration the number of infectious particles produced in the closed room. You can see with the time, the number of infectious particles will be high, so that the chances of infection, if you stay longer, if the area is closed away from ventilation, the chances will be high. Then the proximity. Proximity is how closeness. What is if you stay very close to a contagious person? So if in a household, it is the couples, the husband and wife, or the children, because they stay very close as a unit. So therefore, the chances of getting the infection will be higher if you stay very close to a contagious person. So that is why we recommend staying at a distance. Then the volume in the sense, the volume in the space that you have the exposure. If the volume is less, the chances of infection will be high. So if the contagious person meets in a small room and stays longer time, the chances of infection high. So that is why we say open up, open the glasses, open the windows, open the doors, so that the volume will be increased. So when the volume is increased, the chances of infection will be less. Then the number of infectious cases. So this is very important. So if you have more individuals with infection, the risk of spread will be high. So if you take Brandix cluster or the cluster associated with Paleogoda fish market, we had seen many individuals infected within a small time frame, with a short time gap. This has resulted explosive outbreak within very short time, because the number of infectious cases were high. So the other factor which promote spread is repetition. So if you meet the same contagious person over and over again, so the chances of infection will be high. So that is again, that stresses the home clusters and institutional clusters. If these 5 factors operated in a closed environment such as air-conditioned small room, the infection risk will be high. So what factors reduces the risk? First thing, avoidance of above. So what are the factors that we have to avoid? Time we spend, the proximity we spend, the volume, the number, and the repetition. So if you can avoid selectively these factors, the risk of transmission of COVID will be less. Then open up, let the air come into the room, which allow dilution of potential particles. We know naturally we erect barriers. We erect barriers to separate out patients and your customers and the clients, forgetting that we are effectively reducing the volume that we have. So if any one of us having the disease and become contagious, the risk of increasing, the risk of spreading disease will be high when you have the barriers. Then the filtration. So this is a special situation where you get filtered air into enclosure. If it can be undertaken, it will reduce the risk. But the filtered air is not present in many places, but it is present in certain operation theaters where the risk of infection will be high. The best thing that we can do is wear mask. When you effectively wear mask, the chances of spreading viruses from a contagious individual and also chances of getting virus inhaled into your system will be reduced. Both the positive person will be protected and also negative person will be protected. So it is estimated that in America, if you use mask continuously 24/7, you could have prevented 130,000 deaths within next month if everyone wear mask. So it is very important. So if you wear mask for 24/7 for 28 days in Sri Lanka, we can drop the rate of increase of this current outbreak more than the vaccination. The distancing, as I said earlier, it again reduces the risk. Airflow and ventilation. So this is another thing. So if you allow air to come in and droplets to dilute the droplets, the chances of infection will be. And the most important is reduction in numbers and gatherings and congregates. So when you have more congregates, more gatherings, the chances of infection will be high. So initially, during the Italian outbreak, there had been a football match, which helped the outbreak to spread explosively throughout the country. So reduce the number of gatherings, reduce the congregates, reduce the numbers, you can reduce the transmission rate. Prevention of COVID-19 in healthcare setting. Healthcare setting is a very important setting. It is considered a critical service. So even with the midst or height of outbreak, you can't stop work in the hospitals. So therefore, critical infrastructure and critical services, even if you get few cases, you can't stop, you can close down these things. So it's a very important concept that we have to this. When one healthcare worker gets the disease, in no time, it will spread along other colleagues because they spend more time together. Here you can see from this graph, if one person with the disease comes into contact with other colleagues, you can get an outbreak, a local hospital outbreak of COVID-19 within very short time. Because in the hospital, we stay more time close together. Why? And why we get outbreaks in the hospital is the fact that because we are always thinking, assuming that the disease is brought by the patients. So we take all precautions to avoid transmission from patient to healthcare workers. So up to date, so this is 1 week back, in National Hospital Kandy, where I work, there had been 84 healthcare workers diagnosed with COVID-19. Only two of them, only out of the 84, only two of them linked to patient exposures. All other exposures were due to exposing to ill healthcare workers. So that data shows us clearly when you have this sort of thing, the chances of spreading among healthcare workers will be high. So therefore, to exposure to healthcare, do not. So it is very essential to have a uniform and scientific risk assessment to prevent unnecessary disruption of health services. Therefore, all efforts has to be made on the base home quarantine, strictly scientific basis. Right. So with the background of knowledge that I have given the different concepts, so we will be moving to exposure risk assessment. So this is the highlight of my presentation, exposure risk assessment. Exposure risk assessment need to be carried out in two situations. One, Risk assessment when a group of healthcare workers exposed to a positive patient. So the positive patient, exposure positive patient. We all know that disease can be transmitted from COVID positive patient to a healthcare worker. So when a situation like that happens, we can get the disease. For that, risk assessment can be done. Then the second exposure is when a group of healthcare workers exposed to a positive healthcare worker, a positive COVID positive healthcare worker giving disease to other healthcare workers. So when we are having exposure risk assessment, we have to consider those two aspects. So steps in exposure risk assessment. So there are 4 basic steps. So if you know, if you want to assess your risk of exposure, you have to consider these 4 steps. First one, identification of the index case. Second one, identification of contagious period. So generally, we assume that the contagious period will be 2 days prior to symptoms and 5 days after onset of symptoms. So that time period you have to avoid. Identification of healthcare workers who have exposed and their identification of their risk categories. Then identification of exposure risk and then recommendation. So these steps are very important in exposure risk assessment. So you identify the index case, identify the contagious period, identify the exposed healthcare workers and identify their exposures, and then recommend, depending on their exposures, what actions you have to take for this thing. Identification of risk. So working out the contagious period. The contagious period, as I said, 2 days prior and 5 days after onset of. Find out the significant contacts. So we have to find out the significant contact using knowledge on contact emission. So I have discussed about the contact emission and airborne risk score. Categorization of individual healthcare workers to different risk classes. So there are three risk classes. Low risk. So if the healthcare worker who was subjected to exposure to a contagious person has a low risk, they can continue the work. And if they are in high risk group, we can recommend them for quarantine. And there's a risk factor which is not in low risk and it is not sufficient enough to categorize as high risk. So they are categorized as moderate risk. So when you have moderate risk, you can work in the hospital following the moderate risk precautions. Low risk exposures. If both index case and exposed healthcare workers have met during contagious period, not met during contagious period. So when you are assessing, if the contagious person and the susceptible the person, if they have not met within that infectious or the contagious period, it is considered as a low risk exposure. For that, you have to get the history. Then if the meeting between two is brief and both parties wore masks, the risk will be less. If the meeting between the contagious person and the susceptible person and only one party wears mask and the time spent together is less, so you can consider it as a low risk. If the meeting took place at least 2 meters apart and it's remained short, the chances of getting the disease is less and it is considered as a low risk exposure. The high risk exposures. So these are the exposures that we have to concern. Spending at least 15 minutes with a positive asymptomatic patient without mask. So that is the time duration allows, the maximum tolerable time duration for us to be with a positive person. Spending at least 5 to 10 minutes face to face. Spending a night within the same room. Performing aerosol generating procedure, cough or sneeze from a positive individual, and engaging in oral care. So these are the high risk procedures. So I'll skip this. Important factors to consider when duration of exposure, type of interaction, extent of body contact. So the high contact, the risk is less contact, less. Patient wearing a mask properly, if the contagious person wearing mask properly, type of mask. Healthcare worker not following proper practices like donning and doffing of PPE. Healthcare worker performing, not performing hand hygiene. PPE was soiled and damp and inappropriate PPE. Then I will be discussing about the risk assessment framework. Risk assessment framework is, there are two frameworks that we have decided from, worked out from National Hospital Kandy. The risk assessment framework for group of healthcare workers who exposes to positive healthcare worker, positive patient. So these are the 7 parameters that you have to go through. So depending on these 7 parameters, yes or no answer will be put into this, and we can provide you with this risk parameter. So depending on the answers, the nature of answers to any of these 7 parameters, if one, at least one, get the yes answer, you have to consider that is a high risk exposure and recommend quarantine accordingly. Then the second group of risk assessment is risk assessment when a group of healthcare workers exposed to a positive healthcare worker. Positive healthcare worker, the COVID positive healthcare worker. Here, this framework gives you some idea about the risk categorization after this. So these two templates are very easy and user-friendly and tested. So if you can use this risk assessment tools, so you can verify and quantify the risk, and recommendations can be made depending on this thing. At the moment, these two parameters were used in our hospital for risk assessment of healthcare workers. So there will be basically 2 risk assessment: the local risk assessment conducted by the ward and the unit, and the systemic or the secondary risk assessment conducted by the risk assessment committee. So with that thing, we can shortlist number of individuals who are having high risk, and we'll be secondarily giving them recommendations. So we need to assess the risk in following situations. A healthcare assistant was brought a positive patient to a trolley to admission room. The healthcare worker is wearing a surgical mask, visor, gloves, and an apron. Time of spent is 15 minutes. So what factors to consider? Whether the patient is symptomatic or asymptomatic, whether the patient is coughing or not, whether the patient has worn a mask or type of mask, type of contact and proximity, air volume. So if you go through these factors that I have mentioned earlier, you can easily find out whether this exposure is a significant exposure or a mistake. So another exposure, high risk patient brought to ETU from, so I'll go through. So this is the ETU exposure. You can see a person is brought to ETU following road traffic accident, and then the person was subsequently found as positive for COVID. So what are the risks for other healthcare workers to get the disease? So here with the risk assessment framework, so you can assess the risk and find out whether the healthcare workers are truly having a high risk exposure or not. So if they are having a high risk exposure, you can recommend home quarantine and exit PCR. And if they don't have a high risk exposure, you can reduce the level of precaution to low risk and allow them to work. And if the healthcare workers are neither in high risk or low risk, and you can give you can keep them in moderate risk and still allow them to work and to maintain the critical nature of the healthcare delivery that they do for patients. A positive patient comes with symptoms to OPD, the doctor. Now here you can see the OPD scenario. A doctor sees a person with symptoms, and later he found to be COVID positive. And then what is the risk for doctor? What is the risk for the nurse? And what is the risk for the healthcare assistant? So with the framework that I have shown you, you can very easily find out the risk associated with this. And you can calculate the risk and also recommend whatever the recommendation you can. So idea of having these risk templates is to do the risk assessment and avoid unnecessary quarantine, unnecessary home quarantine of healthcare workers. You know, when you quarantine more healthcare workers after exposure, the number of workers left to do the work is less. So in that case, you will be straining, giving unnecessary strain on healthcare system. So that might lead to fatigue among the existing healthcare workers. So that is why we recommend to have a systematic uh, way of assessing risk of exposure. How do you assess the risk of individual exposures on this day? You can see this is a common scenario in nights when operation theaters or wards. The nurses tend to rest in a very small area. If one nurse gets the disease, so the whole night the nurse will be producing droplets, contagious droplet within a very short area, very short volume, very small volume. So virtually giving the disease to everybody, right? So if you can identify these areas where the chances of getting the disease or conveying the disease or transmitting disease is high, you can selectively try to address them and avoid it, and you can reduce the risk of transmission in the hospital. So if there is a exposure in outside open environment, brief exposure, even with a COVID positive patient, the chance of getting the disease will be very, very minimal. So if that much of that sort of exposure, you don't need to give a uh, home quarantine recommendation. Especially the PHIs, when they recommend home quarantine, they take every possible exposures and they quarantine it. So that is not necessary. And if you do a systematic risk assessment, you can minimize that sort of home quarantine and minimize the risk of, again, traveling in a three-wheeler with a positive individual. So we assume that everybody will get the disease after that. But actually, if you are wearing the mask, you can prevent it, the spread. So here I have tried to give you a demonstration of incidents which taken place in the central province. A doctors party, a group of doctors having a party, giving a party for one of their colleagues who is going to transfer. You can see around 20, 25 doctors were involved in this with a positive healthcare worker. But none of them, everybody believed that you get more cases after that exposure. But only the person, the index curse person, who was positive for that instance, because the fact that they were wearing masks and they were observing distancing, and they have opened up the environment for air to come in. So basically they were following a minimizing risk behavior so that it didn't progress or expanded to a outbreak. So again, there are few others. This thing, a supermarket, positive individuals in supermarket dispensing or giving goods. None of the patients, none of the individuals who entered the supermarket didn't get the uh, infection. So buying from open market, again, even if the Mudalali is positive, there's no risk of getting the infection because there is a lot of volume, dilution effect also, and also the healthcare, the individuals who are going to market will be using the mask. So in that context, you can prevent the disease. So here is a very interesting case. Two families living in a flat. One person, the elderly person, coming with COVID-19 to their home. And this is a 600 square feet apartment, and two families living in with 11 members living in the same precinct. So what happened after 2 weeks, that the person has given the disease to 5 new cases because they were living in a very close proximity. And what happened at the end, the lady, the wife of that particular person, died of COVID because of the fact that they were simply overcrowding the area and there had been more interactions. So in this sort of scenario, it is very difficult to prevent spread. So you have to use mask even within the home. So again, Matugama bus incidents, two individuals were traveling. So they have given the disease to as much as 6 new cases. So that is long distance traveling in an AC compartment without mask. Having deals with the infected healthcare worker. So this is again a situation, a scenario that we have recreated in the hospital. A healthcare worker, symptomatic, giving disease to her colleagues. You can see two of her colleagues got the disease because of the fact that they are high risk behaviors, like they are taking meals together. So if they have practiced this, that is one, taking meals and going out, so that sort of thing, even if they get the disease or if they are having the disease, the chances of spreading will be less. So as healthcare workers, we have to have a clear policy to prevent such instances. In summary, you can see when COVID-19 patient coughs, sneezes directly to a face of a susceptible individual, the risk of acquiring COVID-19 will be very high. If somebody stays in a room or in an enclosure with a COVID-19 patient, the risk will be high. Smaller droplets and particles will remain in air for longer duration. So if a person stays more and comes into the contact with another person within that enclosure, the chances of infection will be high. Moving from enclosure to open space or opening up the doors or opening up the windows will reduce the risk of transmission of COVID-19. The aerosols or suspended particles gradually reduces when the shader is moved out. So therefore, if you come across a person, so try to take him out of the ward or taking out of the place as soon as possible. So if you do that, the chances of getting secondary cases will be less. With the passing time, the amount of infectious virus in respiratory droplets decreases. So when you remove the person, with the time, the droplets will go down. Chance of transmission of COVID-19 depends on amount of viral particle coming into contact with the subject. So the coughing and sneezing, high level of exposure is there. Shouting loud or singing will shed more viral particles. Breathing and soft speech produces less viral particles. With the use of mask, the amount of particles shedding will drop dramatically. So the chance of infection is also goes down. So therefore, as responsible healthcare workers or healthcare providers, we should always wear masks, the appropriate mask, and use the mask appropriately so that we can contribute positively to prevent spread of disease. So if all of the country uses mask 24/7 for 4 weeks continuously, we can effectively drop the new cases by almost 60%. So that is more than the changes that we anticipate from vaccination program. So even with the vaccination program, the anticipated findings will not come into reality, not become a reality if you drop the practice of mask wearing. So again, as the final 2 slides, I'm going to give you this one, which I have posted in my Facebook. COVID-19 වැළඳෙන්නේ ඔබගේ වරදකින් නොවන අතර ඔබෙන් තව කෙනෙකුට පැතිරෙන්නේ ඔබගේ දොසකිනි. සෑම විටකදීම මුව ආවරණ පළඳා COVID-19 බලන්න. Thank you very much. And if there's any questions, I can answer this thing. So I have 5 questions. So it is number 1, we have received first dose of vaccination. What is the risk of getting COVID-19 if we expose to a patient? So that is first dose of vaccination. That means after 2 to 3 weeks time, you will be producing antibodies against COVID-19. So the risk of getting COVID-19, so that is a bit unclear. So if remember, vaccination won't protect you from infection. ඒ කියන්නේ disease එක හැදෙන එක වළකින්නේ නැහැ vaccination එකෙන්. disease එක හැදෙන එක වළකින්නේ නැහැ. It will reduce the severe sequelae of the disease, the COVID-19. So it will definitely reduce COVID-19, the severe sequelae. So that is the critical COVID-19 manifestation, severe COVID-19 manifestation, and death. But it won't reduce the infection. It won't reduce the transmission. Even with the vaccination, even with the first dose or the second dose or subsequent boosters, if you ignore the using, if you don't use the mask, the disease will remain. So there are in other countries where they have rolled out the vaccine, they have found rebound increase in COVID cases due to vaccination process, not due to the vaccination, but due to easing of the masking policy. So therefore, whatever the vaccine, whether it is Pfizer, Moderna, or Covishield, or Sputnik, or Sinovac, whatever the vaccine that you use, you can't stop wearing mask. So if you wear mask and do the vaccination, you can get out of the problem within 1 year. But if you wear mask 24/7, up to 28 days or 4 weeks, you can reduce the number of cases by 60%. So therefore, I stress again, vaccination you have to do, but the number one factor to reduce the outbreak is universal masking. So therefore, the chances of getting infection is still same, but you won't be getting severe sequelae. What is the suitable time period for second dose of COVID vaccination? So again, so there are different thoughts whether we should go ahead with 4 weeks schedule, second dose, or 12-week schedules. So it all are mathematics. With the 4-week schedule, 70% will be protected. With the 12-week schedule, 90% will be protected. So why aren't we recommending 12 weeks? So what my personal thing is, even a single dose is enough to fight this outbreak. Even a single dose is enough. Because after 2 to 4 weeks of getting the vaccine, you will be protected from severe disease, severe manifestation, and you won't die of COVID. So that is the beauty of vaccination. But whether you give it at 4 weeks or 12 weeks, so it is numbers, 70% protection versus 90% protection. But to get that additional 20%, you have to wait how many weeks? 8 weeks. So within that 8 weeks time, you can get the disease. So therefore, if you can achieve a 70% with 4 weeks, so that would be the best thing. So if you can achieve 60% of protection within 2 weeks, so that is preferred. If you can achieve 55% of protection with single dose, so that is the best thing. So whatever the thing that I'm telling you, whether this is 4-week schedule or 12-week schedule or 6-month schedule, so you have to get the vaccination early and roll it out early and give it to masses within very short time. So we don't worry about the second dose, the booster, but we worry about the coverage. So if you give a more coverage, the chances of severe sequel will be less, and therefore you won't be getting more severe cases, and your critical infrastructure, the ICU beds, will be preserved for patients who are needy. Regarding the effectiveness of N95 mask, how often should you change, and how long periods the virus are on surface according to the latest research? So I will answer the second question. So that is, how long does the virus survive in surfaces? In medical microbiology, we call it formites. So the surfaces and the other object, the solid objects. So we don't mind whether the virus stays live for 2 weeks or 5 weeks within a surface. The contribution from fomite transmission, the contact transmission is 10%. The contribution from droplet transmission and aerosol transmission is 90%. So therefore, we should worry about the droplet transmission. So if you cut down the droplet transmission by 50%, you will see a, increase of reduce a rapid reduction of cases within very short time. So if you cut down the fomite transmission by 50%, you won't feel that. So therefore, we don't worry about the fomite transmission, the transmission from the surfaces. We have to worry about the transmission from droplets, because that has 90% contribution for the outbreak. So we don't mind getting 1 or 2 cases, but we mind getting large number of cases within very short time. So therefore, we should not worry about the surfaces. We have to worry about the mask. Mask will protect the droplet transmission. So that contributes for 90% of transmission. Wear mask 4 weeks continuously, appropriately, you can cut down the number of cases. So if you clean the surfaces 1 month continuously with the best antiseptic that you are having or best detergent of having, the rate, the outbreak won't drop to a significant level. It won't, you won't see the difference. So therefore, always wear mask. So I think it is not necessary to worry about the virus survival on surfaces. So therefore, I am not going to discuss on that. So regarding effectivity of N95 masks. So the N95 masks are for healthcare workers. Healthcare workers who are engaging in aerosol generating procedures. So if you wear an N95 mask properly, the chances of preventing the disease transmission is 100%. It is absolute. And how often should you change it? So generally, when you wear the mask, you have to keep the mask till the risk exposure is still there. You can't take it out. You have to keep it till the exposure persists. So if you work, you have to keep it. So you can't take it out, put it back, take it out, put it back, and you can go to tea. So that sort of thing is not allowed in infection prevention. So if your shift is 6 hours, and if you are engaging in the positive patients doing aerosol generating procedures, so you have to keep the mask for full 6 hours. Another thing is N95 mask is not available. So therefore, there's a way of reusing N95 mask. So that, of course, you can do a personal reusing. And the risk performing procedures like cannulation, checking CBS, that is, I think, checking CBS in the sense blood sugar or complete blood count, blood sugar, maybe suturing in the absence of PPE, only the presence of shield and mask. So that is perfectly all right. So the shield and mask is also PPE. So they are part of PPE. So you can do this, check blood pressure, do IV cannulation, and if you wear the surgical mask and the shield. So those are the 2 appropriate personal protective equipments which provides highest level of protection, not the gown. So therefore, this mask and shield is also PPE. So those are the recommended PPE to avoid COVID. So don't worry, you can do IV cannulation, check blood sugar, suturing, only with surgical mask and visor. Nothing, you will be, maybe I can't tell you you are 100% protected, but you are protected to maybe 99%. Not like in 95 mask. So the initially when I have given you the example of ENT clinic, the surgeon stayed in that the premises for 2 4-hour sessions only with a surgical mask without getting the disease. So therefore, a properly worn surgical mask is very good in protecting yourself. What is the effect of double masking? Double masking. Actually speaking, double masking will be, I don't favor using double mask because it reduces a chance of somebody else using the mask. If you wear a mask with shield, that is more than enough. Now, the recent evidence says if you wear two masks, the chances of getting protection will be high. But so that is for a, now if you take single use protection, you may be getting 80% protection. If you double mask it, you will be getting 85% protection. But you are getting 5% increase of protection in using two masks which can be used by somebody else. So therefore, double masking won't provide you additional protection. Use a single mask with visor, so that is more than enough. How would you consider the contagious period in an asymptomatic case? Actually speaking, now we have been following up patients, the healthcare workers. Up to now, around 100 healthcare workers, we have analyzed the symptoms. Only 3 or 4 genuinely asymptomatic patients were there. Genuinely asymptomatic patients. So if you analyze their symptoms, nearly 95% had some sort of symptoms. They were categorized as post-symptomatic. So therefore, the problem doesn't come into play asymptomatic. Actually, they are not truly asymptomatic patients. So they are post-symptomatic. So if you go in the history, and they will at one point, if you ask directly about the symptoms, you can find out that they got the symptoms. So therefore, post-symptomatic or asymptomatic individuals, you can find out the date of exposure, the first day of symptoms. But if you keep on going asking on the individuals, at one point they will tell that I got nasal stuffiness or headache or backache or body aches, and that is the date that you have to consider as the first day of symptoms. An asymptomatic patient we don't want, so we can't diagnose asymptomatic patients. So they will be there and they will just vanish. So if you wear a mask properly, everybody, the problem of asymptomatic exposure won't happen because you are masking. With the mask, you can reduce the droplet production and also the disease. So it will have a natural death. How infectious would one be after being vaccinated and subsequently got infected? Actually, infection risk will be same. Risk will be same. Only problem is the infected person might think that these symptoms are due to vaccine. So they might not use mask, thinking that the effects are due to vaccination, and that will increase the risk. But even with the vaccination, you can't take off the mask. You have to keep the mask. If you keep the mask, wear the mask properly and keep away from the society when you are symptomatic, you will be not spreading the disease. But if you ignore the basic stuff such as masking and distancing with the vaccination, that will have rebound increase in case load. What is the risk of getting COVID when taking PCR from infected patient who cough during the procedure and doctor wearing a PPE? So when you are supposed to take the specimens, the specimen are called aerosol generate. Specimen taking is an aerosol generating procedure. So therefore, you can't take specimens only with a surgical mask and a visor. At least you have to use a specimen collection booth to stay inside and collect the specimen. So therefore, if you are taking specimens with a surgical mask, you can't do that. You have to request for a KN95 mask and a specimen booth to collect the specimen. If the person is coughing to your face, surgical mask will provide you some protection, but that protection is not absolute. If there's a risk of catching COVID when we have taken PCR from infected individuals where we don't follow proper doffing, and yes, so there's a chance of getting infection by proper doffing and dunning if you are not done it properly. So therefore, a training has to be there. A proper training has to be there for proper donning and doffing. And also getting a vaccine, how long does it take to develop effective antibody? So you can say 4 weeks. If the time margin of 4 weeks is left, so that is the time frame to develop the antibodies. but that will provide protection against the infection only 60 to 70%. But it will definitely provide protection against severe manifestation. I would say against death, it would be 100% protection against death. Not, you are not dying if you take vaccination. What is the plate for hand sanitization in preventing COVID rather than hand washing? So both are same. I would say hand washing with soap and water would be better than hand sanitizer, because hand washing, you are using a lot of soap and water. In hand sanitization, sometimes you might not take the proper volume. So the volume recommended is 3 to 5 ml, but you might not use it properly. So therefore, hand washing would be better than hand sanitization. The virus, SARS-CoV-2 is an enveloped virus, and the enveloped viruses are very much susceptible to detergents, that is soap and detergents. So I think I have answered the questions. I think you would have got the uh, proper feedback on your queries. Anyway, even no, you can have a lot of queries. Now this is a request that I am going to make from the GMOA membership, the professionals involving in COVID-19 care. Healthcare is a critical service. So you can't stop work in hospitals because even if you get COVID. So therefore, it is very important to avoid COVID when you're during working. For that, you have to practice what is known as universal masking. You have to wear mask always. If somebody comes into your close to you within 2 meters, both parties has to be with a mask. And you should avoid unnecessary loitering inside small rooms. When you're, especially when you're resting and when you're taking meals or taking tea, don't remove your mask. Ask somebody to take their meals and go, and then come back in turns, and avoid all situations where there can be transmission with no mask. So therefore, please make sure to wear a mask and always give a mask to the patient. And if you are coming closer to the patient, always remember to wear the mask and visor together. Minimize the time period you are spending with the patient. So that is better for the patient as well as you. And if you engage in any aerosol generating procedure, make sure that you wear KN95 or N95 mask and the visor always. And avoid aerosol generating procedures if it is not life threatening or life, uh, if it's not affecting the life of the patient. And always do not try to do the standard examination, history taking, spending too much of time with patients. So always reduce time. So now this is a crisis situation where you have to adapt your medical examination techniques, treatment techniques according to the crisis, to face the crisis. And don't use the conventional way of examining patients. So you have to be rapidly, you have to evolve to face the outbreak. Otherwise, it will go on and infect many healthcare workers.